Hello.
Thank you all for joining us this morning on this beautiful June morning. We have the pleasure this morning of welcoming Tina Ferrona, Director of Media Relations for Hartford HealthCare, and we have Dr. Qureshi. He is a neurosurgeon with our Hartford HealthCare Neuro Institute, and they'll be discussing back and leg pain. So we're looking forward to hearing their presentation. We'll save time at the end for questions. I'm going to hand it over to Tina and Dr. Qureshi. Thank you.
Thank you so much, Nadia. Good morning, everyone. How are you all doing this morning? Beautiful day, right? It's nice to be inside. We have the sun coming through. It's beautiful. Question for all of you. How many of you suffer from back pain or leg pain or have had it at one point or another? I think every hand just about should be going up, right? Okay. So this is a good topic for you guys today because I certainly have back pain and leg pain right now as we speak. So we are so happy and thrilled to be joined by Dr. Nazer Qureshi. He's a neurosurgeon at the Hartford HealthCare Neuroscience Institute. Wonderful to have you with us. Good morning.
Good morning. Thank you for having me.
Oops, I think we need to go ahead. Yep, try it now.
Doesn't seem to work. Oh, it did.
Oh, there you go.
Good morning. Thank you for having me.
There we go. We definitely want people to hear you, Dr. Qureshi. So thank you for joining us. You know, at one point or another, we all suffer from back pain and leg pain. Let's talk about the difference between back pain alone versus leg pain more than back pain. What's the difference?
Yeah, so in axial back pain, which is just pain in your back and not surprised. Oh, really? So there is a different thing that happens is that usually when you have the leg pain, depends on when you have it. So for example, if you have leg pain and you say, I cannot sit like the way you guys are sitting, because when I sit down, my leg pain gets worse and I have to get up and move around. Or sometimes people say that they have to sit like this with the leg straightened out because if they sit like this, the pain gets worse and they just have to get up and move. As opposed to some people who say, sitting is not a problem at all for me. The problem happens as soon as I stand up, or if I stand up for more than 5 minutes, 10 minutes, 15 minutes, or if I walk. I can walk more than 50 feet or 100 feet and then my legs are just tired, I can't walk anymore, I need to sit down. And when I sit down like this, for 5-10 minutes, I can walk some more. So there are two different things. The first one, with just the leg pain more so than the back pain, is more likely than not is because of a disc herniation. So a disc can come out and touch a nerve, and sitting like this, stretch more, and the disc pushes against the nerve and causes the pain. Happens usually in younger folks, 30s, 40s, but it can happen any time. It can happen in 20s, it can happen in later life as well. The other situation when people say that sitting is not a problem, it's only standing and walking that is a problem, that happens usually in 50s, 60s, and 70s, and that is because of what we call spinal stenosis. Stenosis means tightening. So all the nerves are going down filled with a sac full of fluid. So if you can imagine yourself standing in an elevator shaft, and that's your spinal canal where all the nerves are going down with a big, huge, imagine a bag filled with water with big wires hanging inside. And in that elevator, at every floor, you have two doors, one on this side, one on this side, every floor. And that's how where the big wires go out, which are the nerves. Now imagine the same elevator with big padding all around. The size goes small. As we grow older, there are ligaments in there that get thickened up, and this canal size becomes smaller, and that's called stenosis. So when you have a stenosis, there's less space in that elevator shaft for all those nerves to be. They were all squished together. And the treatment for that is different than the treatment for the people with just the back pain and if you have a disc herniation. I think we can just leave it at that and then...
Yeah, no, which was an excellent explanation, by the way. We appreciate that. Very easy to understand. I've always been told, at least with back pain, to alleviate the back pain is to strengthen your core and to have a really good core. Now, this is a group that we're talking about today that walks the mall. So they're all about exercise, which is good on so many levels. But is it true that if you strengthen your core, if you have a tight core, it can alleviate some back pain issues? Now, again, some are unavoidable, but talk about the core.
Yes. So the first thing that I do when I see somebody with a back pain or leg pain, other than getting an MRI and getting a diagnosis and discussing with them, is for their steps in management. The first thing which I recommend is physical therapy, which is sending them to physical therapy or let them go to the Westfarms Mall and walk around like you guys do. The strengthening in the core is that the body positioning is so that you're not slouching, you're not, the position of your body strength helps you by keeping it straight, by keeping the canals open, the foramina open, and it helps in getting the result with exercise and the physical therapy alone before proceeding to a further aggressive form of treatment or surgery or some other thing. So physical therapy and core strengthening exercises are the first step.
And I want to go back to the situational part of it because I'm sure a lot of questions in the audience of people, you know, when they stand up versus when they sit down. What about pain in your leg when you're sitting down versus pain in your legs when you walk or stand, but actually feels better when you sit down? Talk about that situation if anybody in the audience may be experiencing that.
Right. So let's take with the stenosis part. The first, remember that when I mentioned the elevator shaft being tight with padding around it. So what happens is that when you stand up, that canal becomes even narrower. And you see people who have problems who can stand for a shorter period of time or can walk only for a period of time. They find if they go to the mall, or to grocery store or whichever, if they can, what they will do is grab the cart and they put their weight on the cart while walking. So bending forwards a little bit. Similarly, when you see them stand, lean on something so they can bend forwards, and that relieves their back pain and also relieves their leg pain. They can stand a little bit longer. And the reason for that is that when they bend forwards, the canal gets a little bit bigger just with the position. That provides more space for the nerves to feel better that way. When they walk, they have to stand and walk, or just standing straight. The canal narrows and they get usually what they feel is pain going down their thighs. The thighs feel weak and achy, and that's when they sit down. And usually when they sit down, they tend to sit down like this, or put their feet up on something that they feel better, as opposed to sitting like this, the way you guys are sitting. The people with a disc herniation, they would have a pain, and you will find them, as I mentioned earlier, you'll find them sitting at the edge of the seat trying to keep the leg straight, because if they sit like this, they have more pain. So that's really the difference between the stenosis and a disc herniation. Now, there can be multiple other reasons for this, but these are the two major ones that we see all the time in our practice for spinal stenosis as well as for disc herniation. And as I mentioned, with degenerative changes, some vertebrae move a little bit more one on the other, and that's brings you into a different situation, but it's more complicated right now to just go into that. But these are the two main categories that I wanted to differentiate between.
And Dr. Qureshi, you often sometimes hear of a bulged disc versus a herniated disc. Can a bulged disc lead to a herniated disc? What's the difference?
Very good question. So quite often when people get an MRI, whether they're for an MRI from their primary care physician or an emergency physician they have, and they get the report and it says lots of things, a full page worth of stuff that sometimes doesn't make sense, and they say bulging disc here and et cetera, et cetera, et cetera. So bulging, so the disc basically is a shock absorber between the vertebrae. So every single vertebra has a disc in between. And the reason for that is because we are walking, standing, jumping, running all our life, and you need shock absorbers there, just like a bushel in a car, or a sponge that you have on your kitchen counter, which is also kind of soft. Now, to keep it soft, there has to be some soft material in there, which is called the central disc, which is just like little white softer part. And to keep that softer part in its place, the outer rim is made of thicker fibers so that it remains there. So it's like a jelly donut, except it's with crab meat, if you can imagine that. And when you walk and stand, it gives you the shock absorbing effect. As we grow older and we do all the jumping, running, and all the activities in our lives, the central part, which is filled with a little bit of water so that it is cushioning effect, it starts to dry up. Which is the other example I gave you of a sponge on your kitchen counter. When you go away for your vacation and you come back 2 weeks later in the kitchen, and that is very hard and stiff. You put it under the water, it becomes soft again. So as we grow older, the water content of the central part of the disc, it starts getting drier. That's also called the back pain. So what happens is when you stand, jump, or walk with the weight, the central part starts to kind of, that gives you the ability to walk around like this. That sometimes it starts to bulge forward. So the outer rim, which is the more fibrous part, as I mentioned with that donut, it tends to bulge a little bit. That's called a bulging disc. And bulging disc is very common. If there are 25 people of you, he's sitting here, even if you did not have any back pain and you did not have any leg pain, if I did an MRI on you, 10 out of 10 have some bulging, which is of no concern. So even if the report says bulging disc, that may not mean anything. When it becomes a problem is when it bulges too far out. It's called a herniated disc. A herniation is something that comes out through an abnormal opening. So sometimes you can have the disc that pushes out so much that touches the nerve and causes the pain. That fiber, the fibrous rim of that disc, it ruptures and the central part just goes through it, and that's completely extreme. That's very severe. People like this can't walk, can't stand. If you tell them you can send you to therapy, now that it's a good thing to do. If I recommend surgery, they say, can we do it today? It's that much of pain. And they relief like this too as well, which we'll get to in a second.
And when you have that kind of back pain, that kind of debilitating back pain, how does it reach because you often hear of the sciatica nerve that in your leg, and then you get that numbness and that tingling. Is that from a bulge disc as well? How does that happen?
So that is when the disc is herniated or is pushed far back and touches the nerve. So when the nerve is pinched, and sometimes that's also terminology used in the MRI reports, when the nerve is pinched or is compressed, all the places where that nerve goes down to, it takes the sensations from, or the muscles that it supplies, that's where you feel the pain. So a lot of people quite often will have back pain and say, I have pain here and down my shin, and on the outer aspect, sometimes it goes to the top of the foot, sometimes it goes to the bottom of the foot. And that's just because of the nerve, wherever the nerve supplies. And that is also a diagnostic thing that we can find out. We can tell which level is affected depending on what the symptoms are.
I want to talk about, maybe many of you may know this, this is a very educated audience, but maybe some of you don't know, but bladder and bowel issues associated with back pain and the importance of management of that. Can you talk a little bit about the correlation between the bowel and bladder issues?
Absolutely, absolutely.
Whoops.
I think it died. Let's back up again.
There we go.
So what I tell my patients is there are 5 things that can happen when you have a back pain and leg pain. The first thing is the pain that brings it to your attention and makes you go seek medical help, because pain is the biggest blessing that God has given us. If you didn't have any pain, you wouldn't know what you've heard. And that's what you see in diabetics. Sometimes they get sores and ulcers in their foot, and because they're asensate, they don't feel anything, and it continues to get worse before they seek attention. As soon as you have the pain, you won't do something. So the pain is the first thing that brings it to your attention and makes you go seek medical help. The second thing that can happen is numbness and tingling, which is the sensory part. The third thing that happens is weakness. When you say, I think this is
I think we're,
low battery.
oh, it says low battery.
I think it just dies on its own in a second. So the third thing that happens is weakness. So when you realize that when you're walking, you're tripping on the, yeah, it's low battery.
Let's see. Go ahead.
Thank you. So the third thing is weakness. So you realize that you're not lifting your foot up properly and you tend to trip on carpets. You have difficulty going up and down the steps. Or you find that your leg is weaker or heavier, sometimes what people describe. That's the three things. So pain, numbness, tingling, and weakness. Number 4 and 5 are more important, which is the bladder and bowel issues. So what I mean by bladder and bowel issues is that you are unable to control urine. You have a bladder leaks, opens up, the urine leaks, and you didn't realize that you needed to go to the bathroom. And I'm not talking about a little leak of a drop or something that can happen with age. I'm talking about just the bladder emptying and you never realizing that you needed to go to the bathroom, or not being able to control the bowels. And I always tell people that sometimes those who are waiting for a surgery and saying, well, we want to try this, that, and the other first, that I mention it to them not to scare them, but so that they're aware that out of those three things, these two last things, the bladder and bowel, once they happen, it becomes an emergency. You need to have surgery. If you're planning for have surgery and you're thinking that we're going to avoid surgery, first of it's physical therapy and doing other things first, and then you realize that the bladder and bowel issue happens, then you need to have surgery within 24 to 72 hours. Otherwise, it is permanent and does not go away. So, numbness in the perineal region, inability to control bowel or bladder. If it happens, it's an emergency. You need to have the surgery done within a day or two. Then I tell patients to go to the emergency room right away. Otherwise, that will never return, even if you have the surgery. Going back to the pain is the first thing that brings it to your attention. Pain is the first thing that goes away. When you wake up and you say, the pain in my leg is gone. I don't have any pain. I have discomfort in my back because you had surgery, obviously, but that goes away. You give pain medications, the pain in the leg goes away. Numbness and tingling, I describe like this, that the numbness, the longer you have it, the longer it will take to go away. If you have it for numbness in your foot, for example, for 6 months. So I tell them that's not going to go away. The pain will go away, the situation will improve, but the numbness will not. Weakness goes away. It requires some time, depending once again how long you've had it, and then you may require some physical therapy. But I've seen even foot drops, people who cannot move their foot like this, they have a foot drop, and it starts improving very next day. Once again, if it's there for 6 months or longer, then it will go away. The pain, but the weakness won't go away. So those are the 5 things of the importance of bladder and bowel.
Now, you're a neurosurgeon, so some of you might be thinking, if I go and see a neurosurgeon, that automatically means I need surgery. Not necessarily. You talked about conservative methods of treatment first. Can you sort of take us through the gamut of if somebody comes to see you with back pain and or leg pain, take us through the motions. Is it conservative methods of treatment first, all the way up to surgery, and then some of the surgical options available today?
Yeah, so whenever I see a patient, after history and physical exam and discussing with them, review the MRIs with them, and then we discuss what are the options. So just out of the bat, if somebody has a big huge disc, or which I described as an extruded disc. Remember when I mentioned that the fibrous rim is gone and the disc has completely come out and you can't bear any pain, those people are just going to go for surgery right away. And they will be more than happy to have that surgery because they want that pain gone. Other than that, I usually say, okay, well, let's just start with some physical therapy. Have you done any physical therapy? So I send them out for physical therapy for 5 to 6 weeks, and I see them back again. They always have an option to come back earlier if anything changes, obviously. But otherwise, they come back and they say, I feel much better. And then that's maybe the only thing they require. If that doesn't work, the second step would be sometimes an epidural injection, and I send them to the pain management people to get an epidural injection in their back, which is a combination of local anesthetic mixed in with some steroids, which numbs up the nerves and decreases the pain, and they can get up to 3 injections in a year. They can be a week apart or they can be 4 months apart, and that I leave it to the discretion of the management team that I referred you to and the patient themselves, so that they can decide how many injections they would need or if not. So sometimes people have all 3 injections and they come back and say, no, it didn't work. Sometimes people just have 1 or 2 injections and say it worked. Or sometimes they have 1 or 2 injections and say, no, it didn't work, my pain is still there. And then we talk about the other option. So the last option is the surgery, unless you urgently need it. So that is my protocol of going through.
And we're going to take questions, so have your questions ready. I know there's probably going to be a few questions out from the audience, but before we get to the questions, just really quickly, we talked about bulging disc, we talked a little bit about spinal stenosis and surgical treatment options. For the elderly, and you have that spinal stenosis, can they still be candidates for surgery? I know it's on a case-by-case basis, but when you get up to a certain age, surgery is always in question. Talk to us a little bit about that. When you get older, can surgery still be an option?
Absolutely, absolutely. So it's there's no cutoff limit that you say we cannot operate on somebody who's 70 or we cannot operate on somebody who's 80 or 85. Yes, in general, you would want to avoid, and that's what I do. I want to avoid surgery for very young people. I want to avoid surgery for very elderly people, but I want to avoid surgery for anybody who does not want surgery and does not need surgery. Sometimes I find myself on the opposite end of the spectrum when people saying, I want surgery, and I tell them, you don't need surgery. Sometimes they don't feel satisfied, and I think what really convinces them is when I tell them that I'm trained to do surgery, this is how I put food on the table at my home, and I'm telling you, you don't need surgery. So take it and run with it. And then they say, that makes sense. So sometimes I need to convince them otherwise and say, you don't need surgery. But yes, there's no age limit cutoff, but sometimes you do. So.
Okay. All right. Any questions from the audience? We'll start right here with you, right up in the front row. What's your name and your question? Good morning.
Robert, sciatic nerve, when you have a problem with that, is there a solution to it?
Sorry, say that again?
I think it's the sciatic nerve. When it comes down radiates through your back to your leg, is there any pain medication or something you can do? Because it occurs occasionally, but it's not, a major problem with people.
Yeah, definitely. So usually, as I mentioned, when you have the pain, the first person you contact is your primary care physician. And the primary care physician gives you some pain medications, and usually that works. And if it doesn't work, then they say, okay, well, let me send you to a pain management physician or a neurosurgeon or orthopedic spine surgeon, and that's the route they go. So the first thing is medications over the counter, and is medication that a physician prescribes. So there are multiple different medications that they can prescribe, and those can work. So that's also part of the armamentarium of dealing with people who have back and leg pain.
Good morning, sir. What's your question?
When you have a pinched nerve, that will cause the pain. Is the pain a perception of individual, or there is a way that you can measure so it will be quantified? Like a temperature, everybody can be measured,
So if I understand your question correctly, you're saying it's an individual management for people, how they perceive pain. Is that what you're saying?
Yeah.
Yeah, so some people who may have a high threshold for pain, they may be able to tolerate everything. I've seen people with large, huge disc on an MRI, and I would expect them when they come in that they will be writhing in pain, and they're not. So the other thing what I tell my patients is that we treat people, we don't treat pictures. A picture, which is your MRI report or a picture of the MRI, may show you one thing, but if you have no pain, then you do not need to have surgery. So, does that answer your question? Does individual perception of pain and does, I'm trying to understand if that was your question.
What I'm trying to say is, can you quantify the pain?
Quantify?
I know some people always overemphasize that pain.
Yeah, you're right. So the usual way of quantifying the pain in general is you have a visual analog scale, VAS, and we say 0 to 10. 0 is no pain, and 10 is the highest pain. But that's again individual perspective. People might say, "Oh, I have pain of 12," when the scale is from 0 to 10. But so it depends, and there are other ways of quantifying it by physical examination, so you can see if that. So sometimes if somebody might say, "Oh, I have so much pain," and they're sitting and laughing, enjoying their life. So you just kind of think, "You really have that much pain?"
Any other questions? Over there. Getting my exercise this morning from one side of the room to the other. Good morning. What is your question?
At Pilates, they have those reformer machines. So I wonder what your opinion is on that. And was that tighter table or something that people, I don't do that. They hang upside down on that table, you know what I mean? A tilted table or something. I use the reformer machine in physical therapy, but I was wondering what you thought of that and that other type of table.
So when I refer patients to physical therapy, everybody has a different diagnosis, and we just touched upon disc herniation and stenosis. There are multiple other things. So sometimes what happens is people have what we call a spondylolisthesis, which is when one vertebra is slipped a little bit anteriorly. That also happens with degenerative disease, and as we grow older, sometimes it happens. So when I send them to physical therapy, a recliner or not a recliner, sorry, an inverted table, 60 degrees, it helps. So what it does is it uses your own body to stretch out your spine, as opposed to somebody pulling your leg or putting a weight on your leg. So they can just put you on an incline 60 degrees for a little bit, and the weight of your body pulls that vertebra back into alignment, and you can have a brace. But Pilates in itself, I'm not sure exactly how it works, but yes, recliner table and those 60-degree inverted tables do help.
Any other questions? No? Got a couple more here. Good morning. What's your question?
Yeah, my question is if people have like a rheumatoid arthritis, is the leg is considered joint or muscle or the bone, and also the steroid injection treatment, it would that only the temporary reduce the pain. Would that other options to manage the pain for long term besides medication?
Sure. So that's where the MRI comes into handy. So when we look at the MRI, we look at bones, we look at ligaments, vertebrae, nerves, based on the pathology as to what would be the best line of treatment. Rheumatoid arthritis is mostly in the smaller joints in your hands, fingers, neck, and that's the knees as well, but that's usually arthritis. That's different. So you can have this in your back and you may not need surgery. So it only happens when the cassettes are getting bigger, causing the same impingement with the stenosis. So not every back needs surgery. Some do, some don't. As far as the pain management is concerned, if they don't need surgery, then I refer them to pain management. And they have huge list of things they can do. They give injections, facet blocks, and frequency, what they call is burning of the nerve. So it depends on what the pathology is, and they're treated accordingly with medications, injections, so on and so forth.
Sir, you had your arm up. Good morning. What's your question?
Hi, my question, I actually have two questions.
Sure.
First one is, suppose a person has had surgery on laminectomy for spinal stenosis. How likely is that to return? And if the symptoms come back, is it because of the original location, or could it be stenosis happening in a different set of vertebrae? The other question is, if you have extreme surgery, say knee replacement, can that contribute to nerve pain that wasn't there before, for example?
Very good questions, both of them. So I'll deal with the first one that you mentioned. When you have a laminectomy, which is just removal of the back. Remember this go back to the elevator that I told you about, and there were padding around, and the space is narrowed. So you go in from one side, you remove the back wall, and remove the padding from all around, and then you can close. So now you have more space, and you can sometimes open the doors that I mentioned on each level. You can open those doors a little bit bigger so the nerves have more space. That's called a laminectomy and foraminotomy. Can it happen again? The level that you remove everything, it wouldn't. What can happen is, usually happens above or below. And that only happens especially if you have instrumentation, when you have screws there. So the vertebrae are, every vertebra is individual, there's limited movement at every level. If you fix 2 or 3 of them together, so the movement in your spine is taken up by the level above and below. So there's more movement there, above and below, because you fix 2 or 3 together. And that is when stenosis and symptoms start happening at the adjacent, and that's called the adjacent disease. Does not happen all the time, but it can, and it's a known thing that you have one surgery that you can sometimes may require another surgery, and that is just a part of life. It does not mean that's always happens. As far as the question of your knee, if you have a surgery in your knee and you have nerve pain, that nerve pain will not be coming from your back all the way down. You may have numbness here, you have pain from here down. That depends on what surgery was done. So then you will have to see a physician, both your orthopedic surgeon as well as your neurosurgeon, to ascertain whether this new numbness or pain that you have, is it because of your knee surgery, or is it a new thing from your back, or is just a referred pain, or multiple other things. Sometimes you have a knee problem and you walking hop different ways, and then the back has more strain and you have more muscle pain along your back as well. But that would not necessarily mean that you would have pain going all the way down. And if you have that, what is described as a sciatic nerve pain, that may be a separate issue, away, separate from your knee surgery.
Okay, any other questions? I have one more, okay?
You mentioned about unconsciously urinate. Is that during the sleeping or even?
No, this is while you're awake.
What?
While you're awake, not sleep.
You are awake.
Yeah.
So is that any difference between when you are asleep and
It can happen on either or, but it's usually more concerning when somebody is completely awake and alert and sitting and having a conversation with friends, and you suddenly notice all the water going down the legs. It's more concerning then.
Okay, any other questions? I have one more question in the back, and then here we go. Go ahead. Good morning.
Good morning. Does a change in temperature have any effect on your having pain? Change in temperature.
Right. So this is a very typical pain that you have when the weather is wet. Weather is like humid weather. There's rain outside. People can say, you've seen in old comic books, my joints are telling me it's going to rain tomorrow. And that's with the arthritis. That not necessarily mean that you have a disc herniation.
Great questions. Thank you very much. Of course, I always like to end on a high note. We covered a lot today. It's a very popular topic. It's one that a lot of people experience, back and leg pain. Some great questions. What does the future hold? What can we expect in terms of new treatment options or new drugs or anything that we can look forward to? Because you don't have to live with back pain or leg pain, and some people let it get to the point where it's debilitating, but you don't have to. And you talked about some patients where they come in and say, I want surgery. What can we look forward to? What's next?
There's always new things coming, but that, once again, not necessarily mean that everything is going to be needed by every single patient. So, when you say if you have a hammer, everything looks like a nail, and I always warn people against that, because sometimes they come in and say, I want a spinal cord stimulator, and they've never had any surgery, and sometimes they can just have a simple discectomy and they don't need a spinal cord stimulator. So that does not mean that if you see an ad on television and say, ask your doctor about this. Yeah, you can ask, but it does not mean it's going to work for you or that you need it. There are different, regenerative medicine is very big to regenerate the disc. There's disc replacement therapies that was been done for, especially for the neck, but not much in the back was done and worked that much. Then there's plasma-rich therapy that they can have regenerate the disc material. Multiple new things come along. And there are different surgeries as well, which is out of the scope of this conversation, but there are a lot of new things happening.
Which is exciting. It continues to evolve. Well, thank you all for joining us. Thank you all on Facebook for watching us this morning. And of course, thank you, Dr. Nazer Qureshi, a neurosurgeon with the Hartford HealthCare Neuroscience Institute. It's our pleasure to have you. Thank you.
It's my pleasure to be here. Thank you.